The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to Lymphcast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show Lymphcast.
Today's Lymphcast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our Lymphcast show. This is episode 38. We appreciate you being with us. Every show is available on YouTube and on every podcast platform under the sun, just about. We also invite you to visit our website, which is lymphcastnetwork.com. A bevy of information awaits you there. And if you have questions for the doctors, please send them to the following email address, hello@lymphcastnetwork.com. That's hello@lymphcastnetwork.com. Let's go ahead and meet our panel for the evening, and then we will kick off tonight's show from California, Dr. Emily Eicher. Hello, Dr. Eicher. How are you?
Hi, team. I am honored to be here today, and I would love to introduce Dr. Håkan Brorson from Sweden after we start.
Yes, ma'am. We will come right back to you as soon as we get the rest of the doctors involved. From Arizona, Dr. Monica Glavitsky. Hello, Dr. Glavitsky. How are you?
Hello, everybody. I'm very happy and excited about this new episode.
All right, very good. From New York, Jacqueline Sasick and RVT. Hello, Jacqueline. How are you today?
Hi, Paul. I'm doing well. Thank you. Happy to be here.
Yeah, good to have you with us for sure. And from New Jersey, the gentleman who started this show, he is also the founder and owner of VitaSupport MD. They make Vein Formula 1000 and Lymphatic Formula 1000. Physician, surgeon, Dr. John A. Chubak. Hello, Dr. Chubak. How are you?
Hi, Paul. I'm doing well. Looking forward to this evening. It should be an illuminating evening. And I thank our esteemed guest for joining us at the late hour where he is.
Oh, yes. Very late for him. Let's go back to Dr. Emily Eicher out in California. You're going to bring in our special guest. Take it away.
Hi, everybody. And it is really, truly a great honor to present my dear friend, Dr. Håkan Brorson, that we know for quite a few years. And welcome, Håkan. And before we start, you can tell us a little bit about you. Why did you select the plastic surgery, and what was so specific about lymphatic surgeries? As I know you are the pioneer in the surgical interventions for lymphatic diseases, and you can tell us a little bit more about your beginning.
Well, in the beginning, after medical school, I did my intern and then a residency in orthopedic surgery. And during that time, there was 6 months of plastic surgery. And I was quite fascinated about that. And I went back to orthopedics. And then after about 6-7 months, they asked if I could come back. Probably they liked what I did at the plastic surgery department in Malmö. So then I've been there for 30 years. I retired last year. And so plastic surgery in those days, for what we did is malformations like cleft lip palate surgery. We had the traffic accidents where you need to move tissue from the back to cover a compound fracture. Or we had the burns and also cancer surgery, reconstruction after cancer surgery. So in our clinic, we did not do any aesthetic surgery, so just reconstructive surgery. And after some time at the clinic, actually, the boss, when I started, he wrote a thesis in the 60s about the vascular circulation in the leg. And in those days, they did quite other types of surgery, like, for example, the Charles procedure, where you remove the skin and fat down to the muscle fascia and put skin grafts on. The cosmetic result was, of course, not nice, but it relieved the burden for the patient. So when he retired, the next boss, Magnus Åberg, was pretty occupied with the clinic and administration and surgery, and he inherited all the lymphedema patients that were treated in those days, either by surgery or conservative treatment. In those days at the clinic, it didn't exist. And what the patient were given was like, you can take this elastic roll and bandage your leg, and that's it. Or sometimes they were sent to a special hospital for lymphedema for conservative treatment. And then my boss, the new boss, Magnus Åberg, he asked me to participate in an outpatient clinic of lymphedema patients. And of course, I knew what lymphedema was, but I didn't know anything in depth. So we saw about 5-6 patients, and I noticed that some of these patients had a lot of pitting when you press with a thumb on the forearm, like 1 centimeter or 1.5 centimeter. But some of them had minimal pitting, but the arm was still large. So I asked my boss, what is this? There is no edema, but the arm is large. And he said, well, I don't know. And in those days, I was having a research project with a painful fat disorder called Derkum's disease. And I operated 60 of those patients with liposuction to relieve the pain. But that's another story. Anyhow, I was quite experienced with liposuction. So I said, let's do an MRI on these arms. And when the MRI was ready, we saw that there was excess of adipose tissue, very little fluid in those patients, in that patient, but in particular with a minimal or no pitting. So I thought, well, we could remove it by liposuction. And he said, well, is that possible? Well, I've done these 60 Derkum patients, so it's not, I did liposuction of the whole body. So this is just a small part of the body, so it will not be a problem. So when I done the first patient, I changed my research to lymphedema. And the reason was that you never got any grants for pain in obese women with adipose tissue, minor grants, but when you go into lymphedema, there are more opportunities to get grants to continue your research, because I saw that this patient I operated the first time, the arm was normalized and was like the normal arm. So I said, this is something I would really carry out, and I have finished all the Derkum patients, and we'll write about that later. So this is how I came into lymphedema, and then I began to do a lot of arms from all over Sweden. And I remember the first World Congress in Madrid in 1997, when I showed my pictures. I heard later on behind my back that they thought I had manipulated my pictures. They were those old slides, and very famous lymphologists said, I don't mention the names here, but they said, this is nothing I have seen. Maybe Swedes eat different food than around the Mediterranean. And one said that this is science fiction. And that professor from Switzerland, I sent him my thesis from 1998 and wrote in it that liposuction for lymphedema is no longer science fiction. And I got a very nice letter back. So this is how it all started. And after about 8-9 years, we continue with leg lymphedemas. And so we have operated quite a large lymphedemas. The largest one was sent to me by Peter Mortimer in London. He had 20 liters excess, and this guy couldn't work. He couldn't ride his bike that he liked. Now he is full-time working. He can ride his bike, and he's very happy with it. So this is, so if you look at slide 1, for example, you see it's named the algorithm. So when we have an edema that is not been treated, you need to deal with it conservatively to kind of get rid of the fluid component of the excess volume. And with excess volume, I mean the difference between the swollen and normal arm, or swollen leg or normal leg. So we go from this pitting state to the non-pitting state with minimal pitting. And then I know that the patient is compliant with compression. I also know that this volume is what I need to remove. And then finally, we do the liposuction in order to get complete reduction. So it's a very simple algorithm, which I followed for many years. And then, of course, these patients need to wear compression afterwards. They use it 24/7. And Swedish patients are quite compliant because they do what you tell them. And our climate is beneficial because it's not too hot. Now later, I had found that about 8-9% of these patients do not use any garments, even if I have told them to do it. And I haven't published that yet, but that will come in due course. And I think that the reason is that removing the bulk of adipose tissue decreases the load of lymph that needs to be removed. So I have several patients coming because we follow them. In the first time we follow them every year, but nowadays, after 1 year, we send them back to the therapist, and the therapist report back to us. So we put it in our quality register, so we don't lose the patients. And some patients came back and said, "Oh, I haven't used my compression garments because I took it off when I was swimming, and I just wanted to see if it was going to increase in volume," and it didn't. These patients are typically non-obese. They will have a BMI around 20-22. So removing that bulk made the remaining lymph transport able to cope with what needed to be drained. I haven't seen that in legs, but for arms. So our leg patients, they use compression 24/7. And they have to change garments, I would say, when needed. And when is changing of garments needed? Well, it's like you have diabetes. Some patients need 32 units of insulin a day, and some need maybe 16 or 8. So during the first year, we kind of find out how many garments does this patient need in order to prevent recurrence. And when we know that that after 1 year, we can prescribe the number of garments needed for the following year. And then the patient comes back once a year, and we check and we put in the data in our quality follow-up program. And that saves a lot of time because they don't need to come to us every 3 months or so, because we found out exactly what each patient needed. So you have to individualize the compression. And so this kind of setup works very well. We have had about 43 teams from all over the world, I think 4 from the United States, who have been with us during a week and learned how to do it, to see outpatient clinics, and also the algorithm. And the prerequisite, yes?
May I interrupt, sir?
Sure, go ahead.
Fantastic presentation, and dramatic photographs. Congratulations on this incredible work that you have been doing. It's my pleasure to meet you. I have a couple of questions, if you don't mind.
Yeah, sure.
One of the questions that I have no experience with liposuction for lymphedema personally. We have had many people on the show as guests, and I find it a fascinating and inspiring subject and area of surgery, which I hope our program will be instrumental in inspiring more surgeons to follow in your footsteps, to do this incredibly, incredibly important work. I mean, when we look at this first photograph of this woman with the, I should say, actually, the second photograph, the first photograph is very impressive. The second photograph is mind-boggling. I could see why someone who had never seen anything like that could be suspicious that it was science fiction. In today's day, we would think it was maybe Photoshop or digitally remodeled. But of course, we know that this is really your work and remarkable.
Actually, this patient is the lady with 4.2 liters there. She is actually from Poland, and we saw her for about 2 years, and then she's follow up in Poland, and we get the volume measurements each year.
So let me begin with this first question, because this is a question I've been asking, and I really haven't, quite frankly, gotten any satisfactory answer from previous guests. I have a feeling that that's about to change, because you're obviously extremely knowledgeable and extremely experienced. As my training, I'm board certified in general surgery as well as cardiovascular surgery, and for the last 15 years or so, I've been my practice has been limited to peripheral venous surgery, superficial system, primarily venous insufficiency, varicose veins, and phlebolymphodema, etc. So I have no experience in lymphedema surgery, liposuction, and so forth. My question is, early on, when you began this, when you took this incredible challenge on as a young surgeon, in my training in general surgery in the mid-1990s, one of the things that we were cautioned about repeatedly and emphatically was that after a mastectomy with lymph node dissection, at that time we were doing more modified radical mastectomies with more extensive lymphadenectomy and lymph node resection in the axilla. We were trained as general surgeons that arm, that ipsilateral arm, should be treated with the utmost respect. Not only should you never put an IV in that arm, an intravenous line, you should never draw blood from that arm, and even the patient should always wear a wristband in the hospital so that no one even took a blood pressure in that arm, for fear of causing any additional lymphatic damage that could lead to a potentially massive lymphedema response. And so we were so paranoid and terrified to make that mistake in front of our attendings, and as you call them, our bosses, to find out that someone had put an IV in the arm of a patient who had had a mastectomy or drew blood, etc. Were you not petrified, terrified, worried initially to take on these cases and do liposuction, whereby presumably you would be doing a lot of lymphatic damage in the subcutaneous space, that a patient, let's say more like example one, who had, I would say moderate to severe lymphedema in that left arm, but that were you not terrified initially that you would turn patient one into patient two, so to speak?
Not at all. They have lymphedema because lymphatics do not work. So to make a long story short, I did lymphoscintigraphies in about 16 patients. Before surgery, with and without compression garments, I repeated it after 3 and 12 months. So each patient had 6 centigrams. And what we could show is that there were no further decrease in the lymph transport capacity. When you have a lymphedema, lymphatics are gone. That means that liposuction will not further deteriorate the lymphedema. It's already there. So these dilated fibrotic lymph vessels, they are gone. That's why it doesn't. They do not work. So I was not afraid of doing that. And second, there are several papers showing that taking blood from a lymphedema to SARM or taking blood pressure does not do any harm or increase the incidence of getting a lymphedema if you don't have it. That is quite nonsense.
Excellent. So these are all old wives' tales that have been perpetuated over the decades, and I'm glad that. And I said I was quite optimistic that for once I was going to get a definitive answer from someone who really knows what they're talking about, and I appreciate that. I finally have my definitive answer. So because we've heard some guests say, well, it has to do with the plane in which you do the liposuction and the depth and where the various lymphatic vessels are. Your explanation that these lymphatic vessels are simply non-functional and therefore you're not going to do any more damage to them makes the most sense to me.
And also, if you do liposuction for cosmetic reasons on a leg or an arm, you don't destroy the lymphatics if you're an experienced surgeon. I mean, you get the postoperative swelling as everybody get after a surgical intervention. Like when you cut the skin, you get more swelling around the scar, but that will go away in 2 to 3 months. And the same with if you do liposuction for cosmetic reasons on the leg, you get the postoperative swelling, but the lymphatics work. And if there are lymphatic vessels, they kind of manage this. I mean, when you do, for example, when you do a breast reconstruction with a DF flap, I mean a flap from the abdomen up to the thorax, and you use the internal mammary artery to couple the arteries, and you have nearby veins that you use, these breasts do not get any lymphedema. So there is a regenerative process when the surrounding tissues are normal.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Excellent. Now, it makes perfect sense to me. I had quite a bit of experience with the tram flaps and free flaps and so forth at Sloan Kettering as a part of my surgical training. And what you're saying makes perfect sense. Now, one other surgical and technical question. In patients like these, were you ever, it sounds like you were not, but just to be clear, were you ever incorporating brachioplasty as a part of the procedure, or was that completely unnecessary?
Only in one patient.
I'd like to see that picture.
Yeah, you can see it. That is picture number 3.
Okay.
All right.
So this patient had a very fibrotic lymphedema.
Okay.
And so in this case, I did liposuction, and you can see this big sack of skin. I just excised it and stitched it. It's not a problem. And she's doing fine now.
Okay.
I followed her for 15 years. Yeah. So that's the only patient I've done it. Now, there are surgeons, or one surgeon in the US who pulls the skin up, and if it's more like 5 centimeters, he excises it. I don't know why that is, because that increases the dehiscence of the wound, the risk of dehiscence. And when you have a wound that dehisces, then you get a risk of getting infections. I don't know, because in Sweden, everybody is covered by healthcare. I know that liposuction in the US is considered a cosmetic procedure. That means that there is no, up to now at least, no insurance company that will cover the cost for liposuction. So what people are doing, they do microvascular procedures like intravenous shunts, lymph node transfers, or lymph vessel transplantations. And then they do liposuction free at the same time, or something else. And then they present this sometimes and they look the good results I have, but they don't talk so much about the effect of liposuction.
That's a
I think
thing.
I once was in a panel. I said, "Listen, you get good reimbursement from lymphovenous anastomosis or microvascular reconstruction. It's a tricky procedure, and so and then you could do the liposuction for free. So if you turn that around, and American insurance companies would say, well, we don't give you any money for microsurgery, but we'll give you the same amount for liposuction. Would you still do these lymphovenous anastomosis?" And that it was a spontaneous applause from the audience. It was like the new clothes of the king. That is a Danish saga by H.C. Andersen.
Yeah, well, it's like the old game where the plastic surgeons here, they can't get the tummy tuck approved, so they do the tiny umbilical hernia. And the tiny umbilical hernia has this amazing effect on the panis and the lower abdomen that the whole disappears as a result of the umbilical hernia repair.
I think that when I do surgery in Sweden, I don't need to contact any insurance company. Our microsurgeons in Malmö don't believe in microsurgery for lymphedema. I had one colleague who had, right after removing a lot of lymph nodes due to prostate cancer, had lymphovenous anastomosis done in UK. It didn't work. I have several patients among those patients I operated on had vascular procedures done, and nothing came out of it. So I think it's treatment goes where the money is. I know how that works.
That's fantastic. Hold that thought for a moment, please. I'm going to come right back to it. But I do have one more. It's a bit of an aside, but technical question. In that patient with the massive left arm lymphedema, patient number 2, as you describe her, on the chest wall, did she have a partial thickness meshed skin graft on the chest wall, or was there radiation injury? What is that?
I think she had just what you can see there is a mastectomy scar, and then I think she was irradiated. I think there's a little more pigmentation in the axilla. I can't recall now. I can look it up in my register. But
I'm just wondering. Anteriorly, there looks to be a rectangular abnormality. I don't know if it was a skin graft or a burn from radiation.
No, it's not a skin graft. I think she might have had some breast reconstruction as well. This patient I did 15 years ago, so I don't remember all the data about it.
Well, it's not like it was 60 years ago. You don't remember? So anyhow, let me go back to another question. If it were up to you, because this is another great topic that you brought up, and I'm fascinated by it. You discuss 3 options: liposuction, lymphovenous anastomosis, and lymph node transfer. So basically, in a nutshell, do you think there's any role for lymphovenous anastomosis and lymph node transfer? And if so, in which patient populations, please?
So if you look at lymph node transfer, I was opponent on the thesis in Finland, in Åbo. And the thing was that they had done lymph node transfers in animals, rats, and they put the VEGF-C, vascular endothelial growth factor, because the growth factor have a half-time like about 20 hours, but using a virus vector, they could prolong this for maybe 2 weeks or something like that to induce lymphatic growth in those transplanted lymph nodes. So when you looked at the specimens, you could see there was some sprouting towards the lymph nodes in these rats, but it didn't really grow into the lymph nodes. Now, rats are a high potential to have regeneration. Doing this in a 45-year-old woman after breast cancer will not work better than in a rat. So I don't think it's feasible. There are no randomized studies. I think when you do this lymph node transfer, you go into the axilla, you release a lot of scar. It would be interesting just to see what does scar release do. For example, if you put a flap, you take a flap from the abdomen and put it into the scarified tissue in the axilla in order to, and then you can measure the venous pressure before and after, and then you can see that the vein going from the arm had been compressed by the scar tissue. And when you have a venous compression, you get swelling, and by reducing this scar tissue to get normal diameter of the veins, then there would be maybe less load on the arm and so forth. But in the thesis also, they showed lymphoscintigraphies on one patient where you thought that this lymph node postoperatively was lightening up, but that is not a sign of that the patient became better, even if you see the lymph node that lit up after surgery. But if you looked at the preoperative pictures, the lymph node was there before the lymph node was transplanted. So that was an old lymph node that was lightening up a little more on the late 3 to 4 hour pictures. And also there is this problem with where you take the lymph nodes from. In the beginning, there were a lot of problems. When you took the lymph nodes from the groin, you could damage the lymphatics to the leg. And some patients actually had lymphedema of the leg in trying to cure an arm lymphedema. Then going to the lymphovenous anastomosis, I can just put up one paper that was done by a Japanese plastic surgeon, Jiro Maegawa. He did a lot of these patients, and he looked at these patients before and after. And he could then see if there is a difference in the volume reduction in the patients with functioning lymphatics, lymphovenous anastomosis, and those that were traumatized. Both these groups had the same volume reduction, and there was no difference between the groups. And that was a very honest paper. Also, the pioneer of lymph node transfer, her patients were examined by a rehabilitation physician, and he could show that there was no volume reduction, excess volume reduction, as compared to before. So there are a few of these very honest papers in the literature. And I think that when you get a lymphedema, the lymphatics dilate, the valves come apart, the smooth muscle cells in the walls are fibrotised, and then they are gone. They're like eels in rigor mortis. They cannot pump. So for me, and also have seen patients before and after using ICG, I see no difference in the outcome. And so I think it could work when you do it when the lymph nodes are removed. So when you do an axillary clearance, or you do a sentinel node or a level 3, you can put patent blue in the arm, and you can see the leaking lymphatic vessels, and then you could couple them to adjacent veins. This research is ongoing, for example, at the IDMC in Boston by Drew Singal. And also you could ask, why do not all patients, even if you have a complete axillary clearance, why do these women not get the lymphedema? And that is because they are escape routes, lymphatics that do not pass through the axilla. So it goes on the side of the thorax. And that is also investigated by Professor Singal in Boston. So let's see, for example, if you have 100 patients, if 30% of these patients have these escape routes that do not go through axilla, you don't need to do any immediate lymphatic reconstruction. But the future will tell. But I think when you have pristine lymphatics that are not dilated, still pumping, it could work. But still you have to think of a low pressure system that goes into a high pressure system. The low pressure system is the lymphatics and the high pressure is the venous system. So that is my opinion about microsurgery.
Excellent. Thank you so much. Monica, any questions?
Oh, plenty. So first of all, I would like to ask you, is there any technical particularity between liposuction that you do for lymphedema and liposuction that you would do for just obesity?
No, technically, there are some differences. The cannulas are different. So I did in the beginning. I had my cannulas made in our instrument shop because I want the holes in a long line. I don't want them all around. Like, for example, plastic surgeons talk about Mercedes cannulas. There are openings all over, and then you can, if you're very aggressive, you can damage the dermis. And if you damage the dermis, you can get skin necrosis. I've never had the skin necrosis. So when I hold the handle, I know that where the holes are pointing, so I will not damage the skin. That is one point. And in male patients and in women with a male distribution of adipose tissue in the body, these patients tend to have more fibrosis in the distal part of the lower leg. So also I changed from normal handheld liposuction where you go like this to what is called powered liposuction with a cannula that vibrates back and forth, like when you remove concrete in your basement. Like it's very powerful. So therefore I can also operate on fibrotic lymphedemas. And third, when I started liposuction, if you do normal cosmetic liposuction without anything, you just take out 1 liter. 30%, 300 milliliters is whole blood. That means that in the beginning, they had a limit of 2 liters removal, because then you have to remove more than half a liter of blood, 600 milliliters. Then the research about this, and also adding, for example, adrenaline. So if you infuse saline with adrenaline into the tissue and wait for 20, 30 minutes, the small vessels contract. And then when you do remove 1 liter, you only have 3% whole blood instead of 30. So between 3 to 5% in comparison to 30 or 35%. So that revolutionized the cosmetic liposuction, and it became one of the most used procedures all over the world. But since I am an orthopedic surgeon and also done a lot of hand surgery, so when we did the hand surgery, we stopped the blood circulation in the arm, for example, and you could do that up to 2.5 hours. And then will be no bleeding in the arm during the surgery. And then you put the bandage on, and then you release the tourniquet. So I thought, why not combining this? So I sampled specimens with aspirate from old type of liposuction with nothing, with this tumescent solution that you put in, and also when you do it in a bloodless field using a tourniquet. And the least bleeding was when you used a tourniquet. There was almost nothing. So I combine all these things that say if you do liposuction on a leg, you exsanguinate the leg with this S-mark rolls, and then you put the tourniquet as high up as possible on the thigh, and then you put the 250 millimeter mercury, and you could do the liposuction all up to the proximal part of the thigh. And before the releasing the tourniquet, we put custom-made flat-knitted garments on the leg. We sterilize it and put it on the leg. And we had made these garments using measurements on the healthy side. So these are ordered 2 weeks before surgery. And this garment is then put on, and then we release the tourniquet, and the proximal 10 centimeters where the tourniquet has been, we use the tumescence technique. So all this, we don't need to do any blood transfusions. I did a few in the beginning, but now never. So this is the technique, and that's how to do it in a proper way. If you don't do it in this way, patient will bleed more and they will stay longer in the hospital.
Thank you. Well, so you do have several tricks and tips to.
Yes, along the way, I changed it a lot.
But again, and I just ask one question there because I think this is very important. That's a great question, Monica, and a wonderful response. But it sounds to me, doctor, if you were doing cosmetic liposuction, you would use all of those same tips and tricks that you just described. It's just a superior way of doing liposuction. It sounds like to me, it's not necessarily for lymphedema patients.
Well, I would say that when I do cosmetic liposuction on a leg, I use only tumescence solution. Because these are day patients and they go home the same day. And putting a tourniquet on for 2 hours will have a little pain afterwards. And usually these patients are in full anesthesia and they cannot go home in the afternoon. So they go home maybe 1 or 2 days later. So this is, for example, if you, for example, take a lipedema patient, which is quite different, you can do that in stages. And I remove not more than 4 liters in one patient. And using tumescence, there's very little bleeding. You have to wait 30 minutes before you start. And the patient stays in the hospital for 8 hours and then they go home. And never had a problem with that.
Excellent. Thank you.
And I have another question, because obviously you removed the adipose tissue. Have you noticed the difference between so-called normal adipose tissue and adipose tissue in lymphedema patients?
Yes, actually we published this a couple of years ago, and the cells are much larger in lymphedema. So if you take specimens from the same patients from the normal side and the lymphedematous side, you will find that the lymph cells are larger, but that doesn't say so much about the mechanism behind it. The mechanism behind adipose tissue deposition is chronic inflammation, low-grade chronic inflammation that starts the deposition of fat. Actually, you can see this in patients with Graves' disease, with thyroid problem, that they have these eyes coming out of the sockets. And this is due to inflammation in the adipose tissue. And also the eye muscles are hypertrophied and fibrotic. So I also operate these patients, not with liposuction, but I use normal, and we use normal incisions like when you do blepharoplasty incisions, but you go into the orbit between the eye muscles, almost back to the optical nerve, and remove as much as fat as possible. And the eyes come back in normal position, or almost normal position. And that method was popularized from a colleague in Switzerland, George Noever, and is done now by pupils in Germany as well. So I did it. I went to Germany to refine the technique, and I still do it. But that has nothing to do with lymphedema, but it's just pointing out that chronic inflammation leads to adipose tissue deposition. And I think also that in Australia, Dr. Casey Smith on himself injected blood into the subcutaneous tissue, and then found that there was adipose tissue in that area, because blood outside the bloodstream causes local inflammation. You can also see it in young girls falling off a horse and have a large hematoma on the buttock or on the hip. They have a big hematoma that unfortunately was not evacuated because it says in the books that you should not touch it. But if you aspirated that blood after 10 days, nothing will happen. But when you have this crush injury, you have injury to the vessels, you have injury to the lymphatics, and then during 6 to 12 months, all the blood will go away. But what is left is a big lipoma on the hip. And if you do lymphoscintigraphy, you will find that it's normal, and you can just do liposuction in that area to normalize the contour. So inflammation is the main thing causing the deposition of adipose tissue.
Dr. Håkan, I have a question, if I may. The difference between adipose tissue that you aspirate from lymphedema versus lipedema, what do you see?
This the same.
Same?
Yeah, no difference. But I mean, this is just by looking with the eye. When you look at the canister, there's no difference. There is a paper now together with colleagues in Finland by Kari Alitalo and his group and Rika Kivile, that we looked at the proteomics and the genetics of the differences between lymphedematous arm and the normal arm. So I have collected specimens for patients who had lymphedema for more than 10 years and those who have had it within 5 years, and to see if there is any difference between the early stage or late stage. But that will be published next year.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation. And at VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
And I have another question. So are you using, do you use the lymphoscintigraphy routinely?
Only in primary lymphedema, because I want to see the extent of the damage to the lymphatics. I mean, primary lymphedema can debut when the baby is born, or you see it in teenagers, in women, when they have their growth spurt, and then they exceed the lymph transport capacity of the leg, and then you get a lymphedema. Normally, the patient comes and say, I sprained my ankle, or I fell off the horse, and now the leg is getting bigger. But that would eventually come anytime after that, if that had not happened. It was just an injury that increased the need for more drainage of lymph fluid due to the injury per se. So, and then you can see debut of lymphedema in patients that are older and so forth. So The legs I've operated on, half of them are primary and half are secondary, and there is no difference in doing liposuction on that. I find no difference at all. And actually, last week, our paper was published following 64 patients. All patients were followed for 5 years, and all had complete reduction, and it was published in Plastic Reconstructive Surgery Global Open. So you can look at it at PubMed. And also I described the technique. We described the technique in detail.
Okay, I have another question. We have a wealth of knowledge, an oracle before us, so we have to get all of these questions in. My next question would be, I have two, but the next one, since we talked about the teenage girl, something we've talked about quite a bit in our discussions on this program, who presents with lymphedema precox, for example, and as you say, they're going to progress over time. At what point, doctor, do you feel that it's appropriate to intervene surgically? At what point in the development of lymphedema?
I would say that in Sweden now, we have a very good therapists with they are physiotherapists or nurses. So the lymphedema problem is looked upon quite differently than it was when I started, when nobody almost know what is that lymphedema, even if it's in the textbooks on one page of 400 pages. But still, it has evolved a lot, and we have a very academic aspect at the Lund University, the physiotherapy department in rehabilitation of patients. So when these patients have their lymphedema and they get their compression and they follow the rules of using compression, they will not deteriorate. But if they are not provided with the number of garments needed, then it will get bigger and bigger. So when you have a 2-year-old with a lymphedema, they are followed by lymph therapists all the time. I think I operated maybe 1 or 2 teenagers. So most of the patients are like in the 20s and upwards. Excellent. So I mean, early conservative treatment, and with a very skilled lymph therapist, follow these children and keep I think that if you provide these patients with correct compression, you will not have this adipose tissue buildup. There's no science about it, but I think so. Because then you don't have this fluid coming out, and that kinds of causing this local inflammation, or you decrease the amount of inflammation. So it will not deteriorate as in those patients who have no compression at all.
Excellent. And so other than age, meaning beyond the teenage years and into the 20s, what about in terms of physical manifestation, the overall volume of the limb, or the dysymmetry, asymmetry, one limb as compared to the opposite side? Is there a 20% difference, a certain measured volume? Any markers there that we could use as sign?
Yeah, let's take a look at the picture 4. Here we can see the result of the in this patient. This is just a mean excess volume. The excess volume is the difference between the swollen side and the normal side. And here you can see it's almost 1.6 liters, and we get a complete reduction at 6 months, and it stays there during the follow-up time. In this chart, it's about 25 years. But there are, I would say that these patients, they know when they need new garments, because we have said you need 2 sets of garments every 4 months, or 2 sets of garments every 3 months. For example, our routine is that the patient wears a garment 24/7. In the morning, they remove the garment, take a shower, put a skin lotion on, and put a new washed, shrunk garment on the arm or leg. And then the used garment is washed and dried to be used the next day. And these have to be renewed during due to the activity of the patient. For example, if you are 70 years old, you need maybe 2 of these garments every 6 months. But if you are a carpenter with a metastasis of a melanoma in the axilla and you work, you need 2 garments every month. So that's like diabetes. You have to find out how many units that this particular patient need and how many garments that this patient need. For example, leg lymphedema patients, we had 2 flat knitted garments on top of each other daytime, and they sleep with one of them. And we use class 3 and class 2. So then they knew, I mean, if you have a patient with leg lymphedema and you have to renew them every 3 months, or so you have to have 4 of them, 2 of each. So one set on and the other in the washing machine.
Now, let me ask a question, if I can, Doctor. With regard to this dramatic picture that we're referring to of the lower extremity, left lower extremity, correct?
Yeah, picture 5.
Picture 5.
Yeah, this is actually a patient that was the first one that came to us, and he had congenital lymphedema. You can see on the right lower leg there is a lymphedema, but not as pronounced on the left side. And he had a testicular cancer that was removed and irradiated, and then the left leg just blew up. And he said, "Can you help me?" Because I said, "Well, we have just done arms so far, but we kept him away from us because we wanted to have more experience with the arms." But eventually he came to us and said, "You do whatever you want. If it just gets smaller, I'm happy." So he had 14 liters, and this is actually 20 years later. Legs are fine, and he uses garments as he should do, and he works full time. And he actually said, "I just want to be able to put on a pair of jeans and be out with my friends and socialize and go to the pub and have a beer," which you can do now.
You certainly achieved that clinical goal and far more. It's a remarkable case, and congratulations on an incredible result. Now, let me ask you, that was done in one surgical procedure?
Yeah, one surgical procedure, yes.
Amazing.
And if you look at the next picture, picture 6, this lady from Denmark, they tried to do liposuction on her, but they haven't visited us, so they didn't know the concept. So she came to us, and she had about 3-4 centimeter of pitting. When you do the pitting test, you take the thumb. This is the cheapest test in the hospital. You take your thumb, press as hard as possible on the mid-arm or mid-leg, mid-lower leg, and press as hard as, for example, on the leg where the skin is over the tibia. When you feel that you reach down to the tibia, in this case, it was about 4 or 5 centimeters of pit. I have had many physiotherapists visiting us and asked them to do the pitting test, and they just do, "Oh, there is no pitting." But you really have to do it, and you should see the pain in the patient's eyes, then you are on the right track.
And your own eyes, because your thumb hurts so much, correct?
Yes, and my thumb gets white. So this patient on picture 6, so I found a good therapist in Denmark, and she, from picture to the left to the middle, no surgery is done. And this is the concept, what I'm talking about, to remove the fluid of the leg to a state where she now has 5.8 liters, she has 5 to 6 millimeter pitting, then we can do the liposuction. I know how much to remove, and we can use the normal leg or the compression garments that we put on the time of surgery. So this is the concept, get rid of the fluid, minimal pitting, and then you can carry on. And also by that time, I know that the patient is compliant with wearing garments, because you have to get your brain accustomed to this pressure. And if you wear it continuously, it's like you're wearing your watch. You don't think about it because it's just there all the time. So this is how it works. And this is actually, if I could 4 years later, you can see that it says minus 340. That means that the operated leg is actually a little smaller. Now she is working full time. She is married and she's a happy woman in Denmark.
Well, it's incredible. And I want to just comment here. I want to cut in again because I think this is so important for our viewers and our listeners. What's so remarkable about this talks to all of, we're talking a lot of technical, a lot of surgical today, but for our patients involved who look at this picture, if you are someone or if you are close to someone who has a limb like that on the left-hand side, the large leg, huge leg, what the doctor is pointing out is that even in the hands of a qualified therapist with proper hands-on therapy, MLD, nutritional advice, and of course, compression and patient compliance, the middle picture in and of itself is an extraordinary result. And this would be a goal for so many of the patients that I see who are frankly not getting this kind of care here in the United States on a routine basis. And I know Dr. Eicher is providing this kind of care and other guests that we've had. But it would be 5 years ago, if you showed me this picture, I would find it impossible to believe that that result is achieved through non-surgical means. And 5 years ago, if you showed me the last picture, the 4-year post-operative picture, I would also think that that was inconceivable and unattainable as compared to the preoperative picture. So this is extraordinary for our patients to watch, to see that there's hope for you, there's hope for your loved ones, your family members, your friends, and for our physicians watching who are not surgeons or are surgeons, doesn't matter. Don't give up on these patients. These patients are not irretrievable. They're not untreatable. They are not doomed to a lifetime of a massively disfigured and swollen limb. Even in the hands of an excellent therapist, they can have remarkable results. And then in the hands of a great surgeon, and hopefully we're going to be training more and more of them here in the United States. These pictures are just astounding.
Yeah, I would say that there is one thing you need to change in the US. You need to get codes for liposuction okayed by insurance companies, because these patients in the US would need to pay out of pocket.
The problem is that we have here, and hopefully it's not just here, but it has to be done with great caution only because we have so much abuse. We have so much abuse in the country.
Oh, yeah.
Every patient who doesn't want to pay for their cosmetic liposuction suddenly becomes a lipedema patient, a lymphedema patient, a lympholipedema patient, and costs the government billions and billions, and we're already trillions in debt. So it's a major problem because of corruption, unfortunately, and fraudulent behavior in the hands of some unscrupulous physicians. But to your point, it must be done, because what could be more satisfying as a physician than to help a patient with that kind of disfigurement and disability from a physical point of view, from a psychosocial and emotional point of view, et cetera, et cetera. I mean, I get emotional thinking about it and looking at it. Extraordinary, extraordinary.
Just showing the outcome for legs on the 7th picture. You can see that there is, of course, on the 20 years follow-up, as you can see here, there are, of course, fewer patients from the beginning. But what we have found using DEXA measurements, that is dual emission X-ray absorptiometry, is that when you remove the heaviness of the arm, the bulk of the arm, also the muscle tissue hypertrophies when you have a heavy arm, and let's say you have 2 kilograms in the arm. Due to the force that you use every day, every movement you have, you get hypertrophy of the muscles. And removing then the excess adipose tissue, by time the muscle hypertrophy will go back slowly. That is something we have found out. And also we have found out that there are more adipose tissue within the muscle fibers in patients with lymphedema. But the main thing is here to remove the excess subcutaneous fat.
Now I have one other question. As you may or may not know, Dr. Monica Glavitsky, who's on our panel, did 15 years of research in Paris for Servier on Daflon 500 and MPFF, micronized purified flavonoid fraction. And some of the strongest data in the use of micronized purified flavonoid fraction was in upper extremity patients post breast cancer intervention. And Monica, you can correct me if I'm wrong. Doctor, did you have any experience incorporating MPFF into your treatment protocols?
Well, they are not okay to use in Sweden because there is a lack of scientific evidence.
Monica, respond to that.
Well,
and also, I think in Australia it was forbidden because it affected the liver and could get
you
liver
are
problems.
talking about coumarin. It's alpha-benzoyron.
So we don't have Daflon or we don't have coumarins in Sweden, so I have never used them. And that is not regulated by me. It's done by the drug in the department in the Board of National Health Welfare in Sweden, and they look at trials, and if they find that the medication is okay and works, then it will could be used in Sweden. But so far, these pharmaceutical tablets or they cannot be found in Sweden. I think you can buy it in Italy and France and Spain.
Well, all over Europe, but
but not in Scandinavia.
Not in Scandinavia, no.
Oh, so I have no experience with it. So it is my I say if they were good enough, they would be available here.
No, actually, you are right. There is not enough proof to have the registration in this particular indication because it's only one randomized study in patients with the breast cancer-related lymphedema, and a lot of experimental studies, like the studies that Castle Smith actually did in Australia. And that was pretty interesting, but it's all the question, how do you superpose from the animal research into the world of the clinician. And certainly, I hope that in the future it will be more done in the clinical studies.
Yeah, sure. I think the most important thing is to intervene with conservative treatments early to prevent the adipose tissue deposition. And in those cases, actually, we have a case together now, Emily. There is an American from California who wants to come to Sweden to have his leg operated. But to make it easy for him to not fly from San Francisco to Sweden every 3 months, so Emily will take care of the postoperative treatment according to our protocol.
Of course. Dr. Håkan, I would love to ask you a little bit of different thing. You mentioned about Derkum's disease. I just saw a patient with Derkum's nodules pretty much everywhere. And even the literature says most of them are in superficial area. I found on the ultrasound, this was embedded in muscle tissue. How do you approach this? Do you do any liposuction? The patient has exquisite pain when she's sitting. She cannot do anything. And the Derkum's nodules were in the gluteal muscle.
Yeah. All the Derkum patients I have operated on, 60, they have no nodules. They were just obese. They were almost like lipedema patients, but the adipose tissue now, a typical lipedema patient have a small body from the umbilicus up, and they have big legs. This patient was like obese patients. The fat was normally distributed on the whole body. There are 3 variants of Derkum's disease, and one is the one with the palpable nodules, but there are very few of them. And if you go in, you can just make a small incision and you get out like a lipoma like this size. And these are angiolipomas. They are very painful and they tend to come back.
But this one that I saw on the ultrasound, I detected juxta-articular and also in the gluteal muscle, which on the ultrasound, it looks like a little snowball.
Yeah, I would not call it Durkan's disease. I would call it an intramuscular lipoma that you can excise. Okay,
even in the deep muscle.
Oh, yes, sure. I mean, when you put in a hip prosthesis, which I've done thousands of, you go through the gluteal muscles and you just stitch them afterwards. So it's no problem.
Right. Well, thank you. I'll tell the patient, maybe she will see you.
Yeah, okay. But you normally don't do liposuction on lipomas because there's a risk of implanting pathological cells when you use the cannula back and forth. So it's better to make a small incision and get it out.
Okay.
Beautiful discussion. Paul, I think that unfortunately, we're way over time because it's been so stimulating, so interesting, so exciting, so educational. I really enjoyed myself. And we're going to have to bring this session to a close, but certainly, we're going to have Dr. Brorson back again sometime in the future because I think we have 100 more questions.
I'm very grateful to be invited to this session and to spread the knowledge about how to normalize big legs and arms due to lymphedema.
Thank you so much.
This could have been a 3-hour session easily without even preparing, just going for it.
Yeah, anytime.
All right. We want to thank our viewers and listeners. You've been watching and listening to Lymphcast, episode 38. Don't forget to visit our website, lymphcastnetwork.com. Everything is there for you about this show. You can catch us on YouTube and just about every podcast platform under the sun. Certainly Google Podcast, Apple Podcast, Spotify, TuneIn, Stitcher, Amazon, Castro. We are all over the place. Let's go around and thank our panel before we bid you farewell for this episode. From California, Dr. Emily Eicher. Thank you, Dr. Eicher, for everything tonight.
Thank you for the fascinating podcast. Thank you, Dr. Brorson, for joining us. I know it's midnight for you, past midnight. So we thank you very much. And hopefully we join you and you can join us sometimes in the future.
Thank you. I'm very grateful to be able to be with you in this session.
All right. Thank you very much. From Arizona, Dr. Monica Glavitsky. Thank you, Dr. Glavitsky, for all.
Thank you for having me, and thank you, Dr. Brorson, for this fascinating session of the Lymphcast. And I wish you good night.
Thank you. No problem.
All right. Thank you. RVT from New York, Jacqueline Sasek. Jacqueline, thank you very much.
Thank you, Paul, very much. And thank you, Dr. Brorson. The work is incredible. As Dr. Chubak said, it brings tears to my eyes as well. Incredible. Thank you.
And the founder of VitaSupport MD, they make Vein Formula 1000. They make Lymphatic Formula 1000. He is also the founder, creator of this show as well, your Lymphcast show. From New Jersey, physician, surgeon, Dr. John A. Chubak. Thank you, Dr. Chubak, for everything. Go ahead.
Thank you, Paul, and thank you, Dr. Brorson, once again on behalf of all of us. And the one last message I would give for our patients listening, if there's one takeaway, is that there is always hope. There are people out there who have expertise in this area. If you have a swollen limb or more than one swollen limb, upper or lower, keep looking for a physician who is knowledgeable, therapists who are knowledgeable, because we've seen this evening how much just a good therapist, and I don't mean just, I mean how important a good therapist, knowledgeable therapist is in reducing the size of a swollen limb and, of course, getting in the hands of the best physicians, clinicians, and even surgeons when necessary. But unfortunately, some people get to the point where the limb swells to an extent it should never get to begin with under proper care. And that's why we're here at the Lymphcast podcast to bring experts like Dr. Brorson from all around the world to spread his incredible knowledge and share it with us. And it's for you, our listeners, and the patients. That's why we do this This program it's all for you, and there is hope, there is hope, there is hope. Thank you, Dr. Brorson, once again.
Thank you. My pleasure.
All right. Very well said. Great show tonight, everybody.